Okay, so for risk factors for plantar heel pain, you're looking at increased body mass index in non-athletic individuals, limited ankle dorsiflexion range of motion, work-related weight-bearing activities, and running, which makes sense. So for differential diagnoses, we're going to speak about fat pad atrophy, tarsal tunnel syndrome, Baxter's nerve entrapment, calcaneal and talus bone stress injuries, calcaneal spurs, and compartment syndrome. So fat pad atrophy, we mentioned that this could be a component of plantar heel pain presentation, but if you consider this, or if you're considering this to be a driving factor and you want to treat it as well as or separately, here are your differential options. So for pain location, you'd expect pain at the center or margin of the calcaneus or heel on the bottom side. This pain is typically worsens when barefoot or after long periods of standing, and usually it's bilateral, so both sides, not just one side, which you expect with plantar heel pain. So tarsal tunnel syndrome is the entrapment of the tibial nerve underneath the flexor retinaculum on the medial side of the ankle. And this avenue that the nerve travels through is called the tarsal tunnel. So you'd expect pain over this tarsal tunnel behind that medial malleolus. You'd expect your nerve signs, so your burning, tingling, numbness, radiation on the bottom of the foot, plus or minus night symptoms. Rest will often relieve these symptoms. And then your clinical test options are TNELS, which is pain or tingling in the distribution of the nerve, is a positive test. Or the dorsiflexion eversion test, where you passively dorsiflex and evert the ankle to end range, hold for 10 seconds, and check for reproduction of symptoms, which would be a positive test. You may also expect weakness of the foot intrinsic with chronic issues, and it may be exacerbated by prolonged standing or walking. So something to keep in mind there that can be similar to a plantar heel pain or a fat pad issue. So Baxter's nerve entrapment is the entrapment of the first branch of the lateral plantar nerve, and then you'd expect this to be tender at two possible points of entrapment. This is where it gets technical. So between the abductor hallucis and the quadratus plantae, or the anterior aspect of the medial calcaneal tuberosity between the flexor digitorum brevis and quadratus plantae. Those are the two possible points of entrapment, and they're similarly the points where you'd expect pain or tenderness. The second point you'll notice is very similar to plantar heel pain, so also tough to distinguish in certain cases. You'd expect some nerve signs like we talked about previously, as well as sharp radiating pain along the course of this nerve. Clinical tests, again, you have TNELS, which you would do more at the medial aspect of it, and then you may expect this pain to be worse after activity and often at night. So calcaneus and talus bone stress injury or stress fracture will again come up in the medial tibial stress syndrome section. Calcaneal spurs, much like fat pad atrophy, it can be a component of this condition. And note that it's also common in asymptomatic people or individuals, people who don't have plantar heel pain. But it is more common in plantar heel pain. However, it's unclear if this connection is causative or not. So it's unclear whether plantar heel pain drives calcaneal spurs or whether calcaneal spurs drive plantar heel pain. And you'll also notice that you'd expect tenderness in the same area as plantar heel pain, in that medial calcaneal tuberosity area. So differential options here, if you're considering this to be the driver of the condition, would be imaging. So you confirm through medical imaging if treatment may be warranted if conservative approaches to plantar heel pain are ineffective or the condition continues to worsen. And when you're thinking about trying to decide whether your conservative approaches are ineffective, keep in mind that the timeline for recovery in plantar heel pain is typically quite long. So about a third of people can expect improvement in 3 months. 50 to 75% can expect improvement long term over several years. And about 25% of those people can expect complete resolution, but the remainder will have recurrent symptoms. So just keep this in mind about when you're trying to decide if conservative approaches have been ineffective. The condition continuing to worsen, on the other hand, is another reason that you may consider this. Chronic exertional compartment syndrome, uncommon, but possible in the foot. So refer to the Achilles tendinopathy section if you're looking for ways to differentially diagnose this condition. And that's it for this.